Okay. Hi, everyone. Dr. Hassaballa with an ICU lecture series on healthcare musings. Nice to have you with us. So, today we're going to talk about SIMV and how SIMV only belongs in coffee. And I'll explain why. So, SIMV is synchronized, okay? Synchronized, intermittent, mandatory ventilation. Okay, it is an old mode. In the past, there was something called continuous or controlled mandatory ventilation, CMV, which was it will give you whatever rate you dial, whatever tidal volume you dial, independent of the patient. Doesn't matter what the patient's doing. If the patient's wanting to breathe 50 times a minute and you dial in 20, the ventilator will give 20 breaths a minute at 500 cc, whatever you dial in, and irrespective of what the patient wants. That was old CMV, right? So that was very uncomfortable because the patient is bucking the ventilator. It's not working with the patient. Now it's called, assisted volume control, meaning when the ventilator senses the patient wants to take a breath, it delivers the breath at the tidal volume you set. The respiratory rate is a backup. So if the patient doesn't want to breathe, if you set a rate of 20, for example, but the patient doesn't want to breathe 20 times a minute, they'll get 20 breaths. If the patient wants to breathe 25, they'll get 25 breaths at whatever tidal volume you set. That's now called assist control, or volume control, assisted volume control. Synchronized intermittent ventilatory ventilation is a kind of a hybrid between spontaneous breathing and mandatory breathing. So on a SIMV knob mode, you dial in the respiratory rate, you dial in the tidal volume, you dial in the PEEP, which is positive end expiratory pressure. You also dial in a pressure support, and you dial in an FiO2. Okay, so for example, let's say we do 15 at 450, so respiratory of 15, 450, PEEP of +5, pressure support of 10, FiO2 of 50%. Okay, now if the patient is breathing 20 times a minute, for example, they will get 15 breaths at 450 cc's. The remaining 5 will be at a pressure support of 10. Okay? Now, if a pressure support of 10 is not enough pressure to generate a tidal volume of 450, you're going to have 10 breaths that are inadequate. Right? So if a pressure support of 10 only gives the patient a tidal volume of 300, so now they have 15 breaths at 450, and then they have the remaining 10 breaths at only 300. Okay? So this is, and this has been shown in studies, old studies, that it increases work of breathing. Because you're getting only some breaths at the big tidal volume and then little guppy breaths. You know what I mean? So if they're breathing 25 times a minute, so let's make the math easy. 20 times a minute, every 3 seconds. Okay? Every 4 seconds they'll get a 450. The remaining time they'll get pressure support 10. So it's been shown to increase work of breathing. This was the old, what they called weaning mode. I put it in air quotes, weaning mode, because what they do is they slowly decrease the respiratory rate and then have the patient breathe more and more on their own. Well, why are we doing both? It's like half and half. Half and half belongs in coffee. Okay, that's why SIMV belongs in coffee. So now, if you're in the operating room under general anesthesia and you put somebody on SIMV, what is not there? Pressure support's not there because there's no spontaneous breathing. They're generally anesthetized and paralyzed. They're not going to take any spontaneous breaths. So SIMV in the OR looks like assist control. Okay? So yeah, everybody in the OR puts that on SIMV, but it's the same as assist control. Or they used to. I don't know, they've changed, but if you put somebody on SIMV in the operating room when somebody's under general anesthesia, it is the same as assist control. There's no spontaneous breathing. They're only getting what you dial for them because they're paralyzed and generally anesthetized. So now if you, but once they wake up and they start breathing over the respiratory rate you set, they're going to get the whatever pressure support you dial, and it increases their work of breathing. So don't do that. Either have full support, assisted volume control, or have pressure support. It's totally spontaneous. Don't have both. Half and half only belongs in coffee and eggs and other things. It does not belong on a mechanically ventilated patient in the intensive care unit. And like I said, they've shown studies that it increases work of breathing. So why are you doing that to the patient? Now, if somebody insists, I must have SIMV, okay? So what I do to get to it to be like assist control is I just dial up the pressure support to the pressure to give me the same tidal volume. I look at the peak pressure, okay, and I add, if the peak pressure is say 20, the PEEP is at 5, so I will give them a pressure support of 15 to get their peak pressure to be 20, and that should give them a 450 cc time. So the referring physician, I don't want to disparage any colleagues, but the referring physician insists on having SIMV, so I can keep them on SIMV mode, but I can just dial up the pressure support to make it look like, or to make it act like assist control. But we don't use this mode because in the operating room, it's like assist control. So pick. Either want pressure support or you want assist control. SIMV belongs in coffee. It does not belong in the ICU. This is why I don't like SIMV. And for no other reason that it makes the patient breathe. It increases work of breathing. I mean, think about it. You have big breaths, nice big breath, and then another. Oh wow, thank you. Especially someone who just came out of surgery, right? They're just waking up from anesthesia. They're not going to have a lot of effort. So if this pressure support number is too low, they're going to struggle to breathe. Why do that to the patient? That's why we don't do synchronized intermittent mandatory ventilation. It's an old relic of the past that should die like the dinosaurs did. You either want spontaneous breathing with pressure support, or you want assisted volume control. Pick one, and they're equivalent. I can do the same with both. The only difference is on the pressure support. Now, every ventilator has apnea ventilation, so you don't die on the ventilator. But if you turn it off, even though you should never do that, if you turn it off, for instance, just theoretically, on pressure support, it's completely spontaneous. The ventilator will not give you rescue breaths. There's no backup rate. It's totally spontaneous. Whereas, at least on assisted volume control, the respiratory rate you dial in is the backup rate. If you just totally stop breathing, you'll get whatever respiratory rate I dial in. So don't use SIMV, okay? If you have a patient that's admitted to the intensive care unit after surgery, switch them to assist control when you're in the surgical critical care unit, SICU. Don't do SIMV. Okay? That is why I say SIMV belongs in coffee. Thanks everyone for your time and attention. Until next time, this is Dr. Hassaballa signing off on the Healthcare Musings podcast.